Hello, this is Shan Chandrasekhar welcoming you to another delightful part of our programming. As part of the Achievers, we featured some of the finest, highly accomplished people from around the world. We have an extraordinarily distinguished guest in the studio here with us today. He's an authority in the field of internal medicine and rheumatology. We'd like to welcome to the program Dr. Thorne, who is very well known across this country in that respective field. Dr. Thorne, it's an absolute honor having you in the show with us.
It's a privilege to join you and your audience today.
Well, to start with, arthritis is a name that we've heard so many times, but there are different types of arthritis, I believe.
Arthritis is an overarching term for 132 different conditions, which vary from those which arise from trauma, infection, autoimmune, degenerative. So some of my colleagues, for instance in South America and other areas, infection continues to be a significant cause of arthritis. In North America, we see that inflammatory systemic conditions are a very important cause, as well as osteoarthritis, which is really the dominant type of arthritis in the community. The greatest advances have come with what are known as autoimmune diseases. These are the diseases that are commonly known as rheumatoid arthritis, its sister diseases lupus, scleroderma, and such things as that. But we look after the other range as well. People who have a crystal arthritis. Gout is the most common type of crystal arthritis that your viewers would be familiar with. So it's the whole range. But the exciting part about rheumatology is that it is really what we call a cognitive specialty. There aren't a lot of fancy tools. It's speaking with the individual who has a complaint, taking the information like Sherlock Holmes, and figuring out how things fit together, because there often is a pattern. So rheumatology is looking for patterns, because we also have very uncommon diseases, vasculitis. And in that instance, people who specialize in rheumatology are often called those detectives. So if they've come from a cardiologist, a lung physician, a gastroenterologist, a surgeon, it's because they've thought of the areas that are affected by their areas of expertise or specialty and say, I don't get it. Let's send it to a rheumatologist and see if he or she can figure it out.
Now, you said there were 4 aspects to it. The first one was trauma. What is an example of a trauma?
Well, the most common cause one of the commoner causes of trauma or traumatic arthritis is actually sports injuries. So that if you're dealing with a 45 or 50-year-old person who has knee osteoarthritis, you can start the conversation by saying, what sport did you enjoy when you were in high school? Unfortunately, a lot of those kinds of contact sports or impact sports cause contact and impact. So that though we encourage people to be fit and exercise, it's important for them to choose the sports that will be less likely to injure them. So there's a great emphasis these days because people live a long time.
I see.
You know, just 100 years ago now, we have to say, after the First World War, people on average died in the Western world at age 56, and now it's 86.
Wow.
That's almost doubled your lifespan. So it didn't matter if you were a football player in those days, because you would have passed away before you had your osteoarthritis. But now it's a significant impact. So some of the public health now is not only to keep people active, but keep them active in activities that are not going to damage them later on in their life.
Interesting. What are the symptoms for arthritis?
Well, again, so we have the commoner ones are, ouch, I hurt. And that's a very important concept, is that the same symptom will be a symptom for a person who has osteoarthritis, a person who has gout, a person who has an infected joint, and a person who has new onset rheumatoid arthritis.
I see.
So a painful joint only tells you one thing. So most types of painful arthritis for most of the population is fortunately short-lived. So you might have had a viral illness that led to something, or you're a weekend warrior. You did something, you overused something. And it heals because the body has a significant restorative capacity, which is fantastic, and that's the miracle of our lives. But for some people, anything that lasts over 2 to 4, 6 weeks is important. It's particularly important in diseases such as rheumatoid arthritis, which is a chronic disabling arthritis, and the potential to cause damage in joints.
Oh, I see.
So joints that are infected can be damaged very quickly in days or a couple of weeks if not treated. Diseases such as osteoarthritis, however, will take years or decades to progress. Rheumatoid arthritis, which has a moderate to marked degree of inflammatory activity, because it's the inflammation which causes the damage, inflammation gone awry, can cause damage in weeks or months. So that a person who delays assessment because they're trying this or that or think it's going to go away may be delaying the opportunity to treat them in that window of opportunity to clear the disease, care for the disease, get the disease in remission before it can cause any damage.
I see.
So that's part of the exercise we go through. Tell me about yourself. Tell me where you've been. Tell me where you've come from. Tell me what your family is like. Tell me how this began. Tell me what joints began. So it's a bit of a, as I said, like Sherlock Holmes. Sometimes arthritis begins as a monoarthritis. My shoulder hurt. And when my shoulder hurt, it's because I was raking the lawn. It was because I was playing sports. It's because I played with my grandchildren. But then it went to the other shoulder. And then it went to the knee. And then I couldn't use my hands. Sometimes that can occur very quickly. Someone's had a pregnancy. They deliver. Everything's been perfect. A couple of weeks later, they can't hold the child, can't nurse the child. So it can come on in many different fashions. So it's important for people to be vigilant. Think about what had happened and where it's been. Remember that arthritis can also happen in our community who are 2 years old or 4 months old.
Oh, really?
And those people, children, can't tell us because, you know, pain is somewhat of a learned behavior. So that a mother or father might only notice that their child has stopped playing, watches TV more. When they watch them, they limp. Or they have a face of distress because a child before the age of 5 or 7 cannot express pain. Pain, in that sense, pain is a learned behavior. So you have to be a detective from all aspects. I did a clinic in Kenora, which is in the western part of Ontario, a very large First Nations population, about 25%. Many of them didn't speak English. In the Ojibwe language, there is no word for pain.
Really?
So when you ask a First Nations person in that environment, tell me about your pain, they can't. They have no word for it.
Wow.
It's interesting. And that's the kind of thing that we have to take into account. And that's why in our practice, as you know, we depend on looking at multiple aspects of a person's state in order to determine what that state is.
It's interesting. It's fascinating that you talked about your experience in Kenora. Now, with Canada's multicultural population booming, does that make a difference in terms of administration of such healthcare services, in terms of detecting hereditary factors from different parts of the world? Does it have any influence on that?
Well, we do know that using the First Nations as an example, but we'll come back to the questions of our new citizens. In the First Nations population, there's a higher incidence of all the autoimmune diseases. So,
what is an autoimmune disease?
So that's a very good question. The body protects itself with the immune system. And the immune system is meant to protect you from outside influences, bacteria, viruses, fungi. And as you're probably aware, you know, sometimes you'll get a flu shot. When you're an infant, you'll get your measles and your rubella and all that kind of stuff. And that's to instill an immune system for you so that you better defeat those viruses when you're attacked. The immune system has evolved for our body to better identify who we are and recognize it as such, and who we are not, and beat those people off. So most people in your audience will be aware that before you have a blood transfusion, they'll find out what your blood type is. Because if they give you the wrong blood type, the body's immune system of the receiver will identify those cells as not looking very much like me and get rid of those cells. A little more complex to have a kidney transplant. Again, that kidney will be covered with antigens that don't look like you. So you'll reject it. So rejection is the body's immune system. In autoimmune disease, for whatever reason, probably a genetic basis, the body starts recognizing itself as not belonging. So it's developing antibodies against itself. Sometimes it's very specific. So some people will have antibodies developed against the platelets in their blood. So their platelet count drops. Very specific, they bleed. Other people will have a disease such as inflammatory bowel disease, Crohn's disease, or ulcerative colitis. It attacks something in the gut. So the person comes in with symptoms of painful diarrhea, bloody diarrhea. Some people get psoriasis, multiple sclerosis, rheumatoid arthritis, a disease in which the principal target is the joint lining, not the cartilage, which is the target for osteoarthritis, not the bone, those two structures being affected as bystanders. Lupus, which is not an uncommon disorder in East Asians, as well as in people in African origin, is a disease in which multiple antibodies occur. It may affect blood and skin and nerves and heart and lungs and eyes and such things as that, multi-system diseases. So in those instances, it's believed that the body's genetic basis, the DNA mapping, is such that there's a predisposition. And that predisposition is probably triggered from something in the environment, because remember, your genetic makeup began when you were a twinkle in someone's eye. Now that genetic makeup changes a bit through your nurture, okay? We're beginning to learn about that. What chemicals you're exposed to, what food you're exposed to, so that you may be an identical twin, but if you came from different environments because you're separated or whatever, and they've done animal experiments like this, you might be actually quite different in how you respond. So that is the body's immune system, for some reason, turning against itself in a limited fashion to the joints, to the bowel, to the skin, to the nervous system. So the autoimmune disease in textbooks of medicine 50 or 60 years ago were usually in the chapter that says idiopathic. I don't know what's wrong, but something's wrong. And there was a very famous physician just north of here, born north of here in Bond's Head, Sir William Osler. Very famous. He developed the Johns Hopkins School, and he finished his life in Oxford. Wrote one of the first...
There's a hospital named after him.
Yeah. And he was at McGill. We're both graduates of McGill. And he wrote textbooks of medicine, and he wrote about lupus. If I see a patient with lupus coming out in the front door, I go out the back door. Because in those days, it was 95% fatal.
Wow.
Okay. Now, it's the few people who unfortunately we are not able to help. So autoimmune disease, we're learning a lot, particularly from the technology and knowledge that came from the Human Genome Project. You might remember that in the late 90s and early 2000s when they mapped the human genome. Not only did we get the mapping, but we got the technology that allows us to do things to look for other causes of disease. And that's some of the research that we were participating in Newmarket.
Now, talking of research, you just mentioned research. You're an authority in this field, by the way, in terms of research. You are also the president of the past president of the Ontario Rheumatology Association. You were one of the founding members of the Canadian Association as well, and also the research consortium. Tell us about this impressive work that you have done in the field of research in this field.
Well, I've always learned from my patients, and every day, I think we were talking earlier before the show, I have the opportunity to learn multiple times a day because I learn from my patients. And again, that's an old Oslerian statement. You can learn in textbooks, but learning without patients is like navigating without a map. And that's true, and we learn every day, and we have the opportunity when you measure and count and study to learn from a patient and learn how to do it better. When you systematize that, when you put it into a framework, that becomes research. Because research is meant to be shared not just in your own practice, but beyond. And there's research that comes of different types. And I've had the privilege to work in areas of research where we're developing new medications. So we had a lot of activity in developing products such as Celebrex and Vioxx before it was taken off the market. We've been involved in developing the new biologic therapies. So almost all of those that have been developed, Remicade, Humira, Etanercept, or Enbrel. So we've also been involved in developing some new pain medications, some new osteoarthritis medications, and those are called randomized controlled trials. And that's what the Canadian Rheumatology Research Consortium has been primarily focused on, working in global studies, that means international studies across boundaries, to develop and find out the best treatments. But we're also been involved with, and I'm privileged to say, quite successful at helping understand the nature of disease. These are activities that are initiated by the investigators, by people who are interested. These are called cohorts, is another word for them, observational studies. So one's the Canadian Early Arthritis Cohort, another's the Ontario Best Practices Research Initiative, another one's about scleroderma, another one's about the spondyloarthropathies and such things. And by placing the majority of patients in these kinds of consortium, we learn about not only how to help others, but how to improve our own practice. So it's been my dream to try and have the majority of my patients participate in a study so we can learn how to do things better and then share that information.
Interesting. I heard you mention the term osteoarthritis. I've also heard the term osteoporosis. What is the difference?
That's a great question because that is very confusing for many people. And these days, in a disease such as rheumatoid arthritis, that when I was in training 30 years ago, the average age of onset of rheumatoid arthritis was 35. So it generally happened in healthy young women. Today, the average age of onset is 55, so past childbearing. And another 10 or 15 years, the average age will be 65. So we're going from a population that was generally healthy and unimpaired to people who've already experienced some arthritis because of osteoarthritis. So osteoarthritis, we used to call a degenerative arthritis, but we're much more knowledgeable now. Because it is inflammatory, it's just a low-grade inflammation. Osteoarthritis has been around for 100 million years. You can find features of osteoarthritis in dinosaurs, in Egyptian mummies and such things as that. Now, probably the dinosaurs had it from trauma, but we find it all over. But it's actually the most common type of arthritis that we know the least about. It appears to be a cartilage problem, and that's the softer material at the end of bone, the thing that you actually walk on or articulate with. Osteoporosis is a disorder of the bone, in which the bone becomes thinned and becomes more prone to fracture. Okay? So osteoarthritis tends to affect an age group beginning in the 45s to 55, 65. Osteoporosis tends to affect women more than men because testosterone is a better bone builder than estrogen is. So women and men both start losing bone mass after about the age of 30. And that's why it's important when you're younger to drink your milk and get your sunshine and vitamin D and be physically active, because you got to build up that bone mass, because after 30 it goes down. Now women start losing more bone mass after menopause, and that's why they begin to have fractures at around 60 to 65, fractures of their hip, of their pelvis, of their backs, of their wrists, whereas men tend to start fracturing when they're 70 or 75.
I see.
Because that's when their bone mass diminishes. So osteoarthritis is a condition of the cartilage at the end of bone which affects the majority of people who say they have arthritis. But there are subsets of osteoarthritis. Osteoporosis is a disease of bone that also affects the older age group, but leads to fragility fractures, which are not unimportant. 20% of people who have a fragility fracture will pass away in the following year. 40% will have to change their lifestyle because of the fracture. So it's really important to avoid. That's an avoidable disorder. Whereas rheumatoid arthritis is a disease of the joint lining. It's the synovium. And that synovium, because of its proximity, it's part of your joint capsule. So it attaches near the bone and the cartilage, and thus affects cartilage and bone in its destructive process. Each of them are, the osteoarthritis and rheumatoid arthritis are characterized by pain as a manifestation of that process. Osteoporosis is silent until you fracture.
In terms of symptoms, as we were talking earlier, the younger generation at this stage do not have to worry, whereas in the South Asian community, whether you are young or old, there is a high risk of exposure to diabetes and heart and stroke and illnesses leading as a result of diabetes. I presume there is no hereditary factor like this in arthritis or osteoporosis.
Osteoporosis is actually more common in Southeast Asian.
Really? I see.
Yeah, and again, because people are living longer, so they're experiencing it. And there are dietary differences between the cultural groups. So when you take any Asian population, whether it's Far Eastern or Middle East or Southeast Asian, there's more osteoporosis. In terms of inflammatory joint disease, you do see them more often in the in a bit of a higher proportion, but it is scattered depending on that group. One of the challenges we face when we deal with our new Canadians is the lack of awareness of these diagnoses from their home cultures. Because I think there's more things that keep them concerned in their healthcare from their original cultures. Things like infection and trauma and things like that. So arthritis is often seen because of the impact of osteoarthritis on people's awareness of arthritis as something that happens when you get old. And I guess I'm just getting old sooner. I got it from my mom. I got it from my dad. So it is often harder to get the immigrant population to appreciate that arthritis is actually manageable. And I would say that if I had to look at populations that come later in the diagnosis, it's immigrant population and First Nations population. And I think they come from not similar backgrounds, obviously, but a culture in which arthritis is not a dominant feature, but it's no less important.
Interesting. But again, our hearty congratulations to you, because you're a trailblazer in this, because your program that you have set up at South Lake and your arthritis program has been looked up to by the rest of the country. So you're leaders in this, and I really want to wish you all the best.
It's a privilege to join you and your audience today.